Hello dear colleagues, and today we continue our course about intelligent decision support systems, and my name is K.Koshechkin, and this course was provided by Gleb Nemkovsky. Our topic for today will be intermediaries and their place in healthcare system and how healthcare financing is really working with them. The objective of this topic will be to describe the main tools that intermediaries, insurance companies, and other facilities use for influence and how they will affect costs and quality of healthcare. I will once again repeat that in intermediaries we will include insurance companies, different funds, as well as government payers and so on. They're essential to the functioning of the healthcare system because they will provide a mechanism for pooling risks by assuming the risk of individual patients and combining them into a mutual support funds. They process payments to serve as providers to determine the rules for provision of healthcare services, and these rules are needed to affect how and what extent help will be provided to the patients and how they will use these medical services. There could be public intermediaries managed by under different aspects of public authorities, and private intermediaries. For example, it could be different private companies, insurance companies, and so on. So they will work with three main groups. It will be healthcare providers, and intermediaries are in the process of developing of a system of interaction with healthcare providers to be able to work with the structures, with the patients, and so they will be covered by the services provided by them. Another stakeholder here will be patients, and there are always some terms and conditions under which patients will receive this support from intermediaries. I guess all of us understand how insurance works, and we need to have one to be able to get required healthcare, and there are often different discussions about terms of these relations and how to receive more services for the less cost, for example, from the point of view of the patient, and what are the conditions for the provision of these services. And the third entity will be buyers. It will be people or organizations which will provide payments for this insurance coverage, and in many cases it will be some kind of organized buyers. For example, one company will decide to acquire additional healthcare support for their employees, and they will be certain delegates which will negotiate with insurance company on the terms of this coverage. So the way intermediaries work with providers and patients will affect people satisfaction with their products. So it will depend on the requirements of the patients if they will be pleased with these services. And the way of work with healthcare providers also affect amount of funds they will be able to request for the services. So facilitators will search for the ways how to work with patients and providers and maintain these relationships and how to monitor this patient satisfaction with the treatment they receive. And in addition, intermediaries regulate what kind of treatment these providers will give to the patients and under which conditions it will be performed. And as a result, it will produce topics for cost control and payment allocation. In a broader aspect, intermediaries will work with high and rising healthcare costs, and in many situations they will work in conditions when they have limited funds and request for care will be higher than available funds. It's a real life situation. So they will have a request for high quality medical care provision under limited resources. And it could be done only in one way. They need to have tools to assess how correctly this healthcare system works and how good these healthcare services are being provided. And to make it done, intermediaries will have a variety of tools that they will use as their way to influence these connections and to assess these medical services. And of course, they will work with costs of healthcare in general. And we will continue with these tools and how they are able to work with them. First of all, we will need to understand the availability of these resources for the patients and how the network of healthcare services provision is working. And the key issue here is to decide which providers and which providers do we have to work. And in some countries, large intermediaries or government agencies are influencing the all of the providers in general. So it could be large state intermediaries such as governmental funds for healthcare. Of course, they will be connected to almost all healthcare providers, at least all government-funded healthcare providers. And once again, I guess it will be good to repeat our terminology. Under network of healthcare providers, we understand group of organizations, a set of providers, which will be located in different cities, different regions, and they are working under certain terms provided by the regional or federal ministries and so on. Of course, here we will need to have some criteria to choose between different providers. And to assess them, we will need to understand the quality, the efficiency, cost of service, and location. And these attributes could be addressed to almost all members of this network. And in addition to define the network, intermediaries set the rules that they will apply to the participants of this network regarding the selection of providers. So in many situations, you will need to meet certain requirements to be able to join such a network. So In general, the idea is that intermediary will be able to select with which healthcare providers they will be able to work, and they will select some of them which will meet their requirements regarding the stated metrics on this slide. There are two options how the system could work. System could be a closed one, and this means that there is a specific list of organizations provided by the intermediary, which is built in this healthcare part of the healthcare system. And this intermediary or insurance company will work with only this list of healthcare organizations. In an open insurance system, intermediary allow its patients to go to the almost any service provider at will. So they are free to decide where they will address their needs. Sometimes we can say that insurance has a semi-open or semi-closed system. The intermediaries set up the network, and then they will be able to add additional healthcare providers on demand. So they will be able to assess these organizations before letting them to receive payments for their services. And this situation will be able to provide incentives for payers to reduce their costs, because there always will be an open possibility to add additional member in this network, which will provide his services for the less cost than less payment than the others. So it's one of the ways to optimize the payments for the healthcare insurance for the companies. Second tool will be supplier payment methods and levels of coverage. Intermediaries are involved in determining the structures of and governing of the payments to service providers. They use this participation as a tool that they can use to influence on the services and costs. And depending on the context, this process can be more or less one-sided. An intermediary with lots of influence, such as a state fund, for example, can gain significant control over the structure. On the other hand, the dynamics of the interaction between the supplier and the intermediary are more likely to be a negotiations one. When both intermediaries and suppliers have comparable power, negotiations can be more beneficial for all participants in the healthcare system. As I remember from our previous lecture, the structure of payment mechanism can be provided on several levels. The first dimension is in the form of payment. To pay for the services of individual doctor or the service of other medical or paramedical specialists per service, it will be one way of the payment system. Another one is per capita payments, and another one could be occasional payments, and all of these methods are acceptable. For hospitals, pay per service, daily rate, and other budgeting systems could be applied. The second dimension is the level of payments. So there could be more or less costly methods which could be provided to treat a certain patient. And when we have different levels of coverage for different types of patients, they can choose which method to select to treat this patient. So these payments could be higher or lower in dependence to this level of coverage. What's really interesting is the interaction between the selective conclusions or contracts and the negotiations between payment providers and service providers. Occasionally, you may see selective contracting used to improve the plans and bargaining powers with several providers. The third tool will be cost sharing with the patient. Intermediaries often used cost sharing with the patient to influence the use of certain providers and reduce their own treatment costs. Out-of-pocket payment, it will be money that patients pay to the providers when they receive care. And these cost-sharing methods could be deductible, the amount that the patient has to pay out of pocket before an intermediary starts contributing to the cost of treatment. Another way is co-payments, a payment that a patient must make each time they go to a provider. The third way is so-called co-insurance, a percentage of the bill that the patient is responsible for when contacting the provider. I guess this idea is quite a beneficial one because when patient need to pay some part of amount each time he will address his needs to the medical facility, he will be more responsible in receiving this treatment, and he will stick with these recommendations of the doctors, and he will be more responsible in his own treatment. So these deductibles, co-pays or co-insurances can have many combinations, so we can combine these ways of co-payment in different ways. Cost allocation options could be also different for different types of services. For example, it could be determined by the level of expenditure relative to the cash limit or cash maximum or something like that. By the status of the provider's network, for example. By level of the service. The main thing is that by providing patients with certain incentives, they direct themselves toward more effective and more thoughtful choices regarding the treatment they really need, and that which of them are more worthy for this patient. The fourth tool will be the use of evaluation, so-called gatekeeper concept, and other direct healthcare intervention methods. It's a set of different tools for directly monitoring of or managing the use of healthcare services. The concept of gatekeeper is a requirement that patients be referred to a specific physician or healthcare provider for primary care, and subsequently contact with this physician or organization as a first point of contact for the medical problem that arises. Provided it will be provided by this healthcare facility as a part of medical services which are being covered by insurance. Before going to a specialist, for example, or getting tested, person need to set a primary care doctor to see his primary care doctor and get a referral from them. Usage assessment. And it's an umbrella term that refers to planning efforts to monitor patients' utilization and attempting to participate in decisions about seeking care. Traditionally, there are three main types. The first type is pre-authorization or pre-review. This is a requirement that the intermediary must approve the use of certain services before the service is provided. And after that, insurance covers the medical care and will answer if there is any questions in this process. If there any questions will arise, they will be able to solve them. Intermediaries may, for example, require the payment to try a less payment from a patient to try more expensive therapy, or they will stick with less expensive one. And they have lists of these therapies which they are able to provide for the patient to select. And there is, in many cases, an option for the patient to be able to switch to a more expensive one. And this plan may target pre-approval requirements in services where there is a potential for overuse of expensive services and the rejection of cheaper ones. The second type is a parallel assessment. The insurance contract provides for the control or the receipt of assistance and the ability of the insurance company to influence the treatment. This is most often done during the hospital stay of the patient. And their insurance agents will contact the hospital if they believe that the patient is staying for too long, for example, and the doctor or administrator must justify why the patient is still in the hospital. The third type is retrospective evaluation. It's also possible to complete the provision of assistance and insurance agents can analyze the assistance provided and check if everything is appropriate. And in many cases, the third option is being used as in previous times because there was no option to real live connection between different systems and to provide real-time data about services which are being provided. There are also other ways in which the intermediary and his representatives can affect the medical care which is being provided. They can track vendors by collecting data of their delivery of certain services. It could be quality metrics and so on. And then provide vendors with the feedback that may affect the use of the services. As they work with patients, they can send reminders and other information to patients to try to influence the use of care. And when we're talking about the fifth tool, it will be insurance coverage decisions. It will impact on healthcare usage and costs by limiting the number of services that insurance will cover. Typically, insurance plans aim to cover a fairly wide range of services.
typically trying to cover services that are medically necessary, so it will be the first necessity. That it will be services that medical professionals usually say are guaranteed or indicated to the patient. Some intermediaries may not refuse to cover all the costs of treatment. Examples of criteria for insurance coverage in these decisions will be efficiency, cost, or profitability. One area in which questions about these coverage decisions have come up frequently lately is with new drugs and expensive new treatment methods. These methods are raising a lot of doubts about their own cost effectiveness. When evaluating an intermediary, it's desirable to evaluate specific objectives that the consolidator pursues to declare. Service providers with whom the intermediary works, how it does its business and competes with other intermediaries, approach to achieving its goals, applying extensive existing tools and sometimes creating new ones, adapting to changes, and this could differ in certain ways. It could be combining different tools and methods and using these tools to a greater or lesser extent. Let's take a closer look at standard life insurance profiles. These include traditional insurance or traditional indemnity insurance, health maintenance organization, recommended supplier list organizations, and managed care. Traditional insurance or traditional indemnity insurance, a method that stereotypically involves minimal use of tools. It will use open network. Payments will be provided for the service. There will be no gatekeepers. There will be a limited use of usage assessment and often a higher proportion of costs in patients. Health maintenance organizations are one of the types of insurance companies that are popular in the healthcare insurance market. HMOs for the monthly or annual fee provide healthcare insurance plans primarily focused on prevention and health maintenance. Perhaps different from other traditional insurance companies that focus on treating people after they have fallen ill rather than maintaining their health. HMOs are in many ways the opposite of traditional indemnity insurance. Defined network and closed organizations, it will have stronger incentive to pay suppliers. It will use overall access and usage control, often less patient involvement in costs, and the gatekeeper concept is involved. And the next one will be preferred provider organization. It's a list of recommended specialists and treatment facilities. a type of health plan that contracts with healthcare providers such as hospitals and doctors to create a network of providers participating in the program. By using these services of the providers who are part of the plan in this network, costs are being reduced. Out-of-network service providers are used for additional fee, and if it could be a crossover with traditional indemnification and HMOs. It will use semi-open or semi-closed model. There will be moderate incentives to pay suppliers, and they usually use gatekeeping concept. And they will use in some part cost sharing with the patient. The concept of managed care is defined as plans in which a mediator makes some effort to manage the care of its members through mediation tools. HMOs and PPOs can be examples of managed care plans. The following are two examples of recent advances in the development of insurance plans. A plan with a high deductibles, general structure for which will be similar to PPO but with a higher deductibles. It will has lower insurance premiums. Narrow network plan is another type of these plans. It will have general structure similar to HMO or PPO, but with a smaller, more selected network of suppliers. Usually we separate private insurers from public intermediaries. Many countries use a combination of intermediaries, multiple public plans, multiple private plans, public and private plans, combination of them to meet their needs. And this will depend deeply on the history of healthcare system, norms and expectations of the population, as well as multiple other factors. There is a difference between a draft plan and a plan type. Some private insurance companies actually offer several options for specific plans, each with its own way. Some government intermediaries will do the same thing. To sum up, we can define the most common tasks of intelligent systems that are necessary for intermediaries. What management tools to use and how to use them correctly. Which suppliers should I contract with? Which providers in the network should I discard? Getting backward to the development plans, payment plans approach. Who are the beneficiaries of compensative health insurance? What are pre-authorization requests and how they could be applied? How long for patient to stay in hospital? It could be also assessed by the systems. What is the best way to set up cost allocation? We can provide a search for the most likely clients and we can start negotiations with them in the systems. We are able to process medical claims. We are able to process medical invoices. and we can assess which of these claims are payable and which of them are not. Also, we will need to be able to search for medical errors, to correctly made invoices, medical frauds, and so on. So there is a lot of ways how we can apply intelligent systems to aid the fund spending in healthcare system. For today it's all. Thank you very much for your attention.